Okay, so we're gonna start. We have some people that are coming from faraway places, it appears, that may or may not get here on time. So we're gonna, since you guys are here, we're not going to take more time waiting for anybody else, but we will let them catch up if they show up. So we have an interesting afternoon planned, and we appreciate the fact that everyone has taken the time from your practices and your family to come an extra day to be here this afternoon. I just got here because of the storm, so I'm sure that there are other people that are stuck from the Northeast trying to get here today. So what we're going to do today is a little bit unique, I hope. I hope you find it to be unique. We're going to go through several different concepts, and then we're going to do some hands-on exercise, and we're very fortunate to have the companies that are supporting our program here. We have W&H that are, as you can see, the handpieces and the motors. And Brian is here, or was here a minute ago, and there he is. Brian's in the back from W&H. We have the implants and the implant surgical kits that we're going to be using from IDS, from Megagen. We're going to be playing with the any ridge implants that you will see has some unique characteristics to it. And what we're going to do that is really interesting, you know, from a standpoint of using Ostel's technology. I hope you will appreciate how we put together this program, because when you leave here and you get a button like this about do you ISQ, hopefully you'll understand what that means very, very clearly by the end of our session. So since we have a small group as well, I'm very open to any kind of questions at any time, especially when we get to the hands-on portion. We have Scott here from IDS who will be happy to help out with the drilling kit, and a whole bunch of people here from Ostel, of course, that will be helping us along the way. So let me give you a little bit of background and some history that I think is really important, and that is that there's two things that I do not place implants without. Number one, cone beam CT, and number two, an Ostel device to measure ISQ. And I don't say that lightly, because number one, from a diagnostic standpoint, when you're taking a look at the situation that we have here, if I go back one and we see the bone, well, we can look at a periapical X-ray, we can look at a panoramic X-ray, but the reality of anatomy for this particular patient, if we're going to assess an implant receptor site, it's not just about the distance between the teeth, it's the distance really between the roots. And the only way that we can truly assess that is to be able to understand exactly the topographical position, both of the clinical crown and then the root position. And as you can see on the patient's left side, there's plenty of room. On the patient's right side, we have a little bit of a delaceration of the central incisor. The other issue, of course, is the type of bone that we have that we can't assess even from this view. We need to look at other views, and we'll go into that in a little bit more detail. But the first part of that equation is under the concept of diagnosis. So, I mean, we're here at the Academy of Osseointegration meeting, and we all understand that we're here to place implants, to do bone grafting, to be able to restore patients that have lost dentition. The reality is our patients are coming to us because they need teeth. And so we need to be able to place implants that we can support the teeth with, so that the patients can be returned to the best function and aesthetics that we can do. And so when we start to look at the positions of the tooth and the bone, we also have to be able to understand the thickness of the cortical plates, the density of the bone, and all of this is something that we can diagnose preoperatively when we're dealing with three-dimensional imaging technology. So I've kind of dedicated my career in the last more than 30 years. I started with CT in 1985. So, and I've been very fortunate to have been invited to the Academy here many times, I don't know, maybe 20 some odd times over the last 30 years to present. And I've been fortunate to also have been able to contribute to about 14 different textbooks. If you take a look at a couple here that are important, I think that this one, and this is already in the second edition by Stu Fromm, Dental Implant Complications, Etiology, Prevention, and Treatment. I think that's one of the best books to have in our library today. However, saying that, when we start to look at etiology, prevention, and treatment, and you look at a lot of the chapters in the textbooks, people are placing implants, they're restoring implants, but they really don't know the stability of those implants because they're either measuring them by tapping on it and making a nice sound, or they're doing a reverse torque test, which can be very destructive. But there really is no objective measure along the entire length of that implant, the placement, the uncovery, the restoration, to be able to give us confidence that we can restore these implants after they're placed. And so I think we can avoid a lot of implant complications by using some of the tools that we're going to share with you today. When we take a look at some of the other textbooks, another one that I'm very proud of, Peterson's Principles, and I just have a chapter in Fonseca's book, which will be coming out very shortly. Implant Site Development with Michael Sonic and Debbie Wong. Again, if you're interested in bone grafting, and we can talk about a lot of that stuff later, very, very important. But again, if you're going to place an implant into a grafted site, if you're placing an implant into a grafted site, what gives you the confidence in terms of when you should load that implant? And this is really an important question, and this is what we hope to be able to answer today. And in fact, I'm the editor of Cone Beam International, Cone Beam magazine, which is available through Dental Tribune International. I'm sure they'll be here at this meeting. And you can get this online. Just search for Dental Tribune International and go to their e-papers, and you can download for free, or you can subscribe to the hard copy. And I'm very proud of that as well. But more importantly, I think, or my latest textbook, which kind of puts everything together, and I'll pass this around later, this is now, I think a culmination of about 3.5 years of work, actually about more than 30 years altogether, but with two colleagues from Italy, Marco Rinaldi and Angelo Mattolo. And we're talking about all this incredible grafting that we can do as a foundation for placing implants. And again, this is about guided surgery, but guided surgery not just for placing implants, for bone grafting. So again, the question is, if you're going to spend all this time, you're going to take a graft from the ramus and you're going to move it, or you're going to do a ridge splitting technique, or you're going to do a sinus augmentation, and then you're going to go in and place implants, wouldn't you want to know that you have a stable foundation to do that? And really, we don't have a true scientific assessment about the quality of that bone. Even with cone beam CT, you can look at it, it may look dense, but it's the feel that counts. And when that implant goes in, you want to be able to measure whether it's stable or not. And that's hopefully what we're going to do today. I'm very proud that in fact, this book has now been translated into Chinese, one of the biggest populations in the world, if not the biggest. And it's amazing the technology that's going on in China right now. And so when we reach the world, literally with Facebook, and I think that we're going to be broadcasting live today as well. And so when we have the opportunity to have the world getting smaller and smaller, we can learn from our colleagues. And you can look at on Facebook, you can look on YouTube, you can look on Twitter, and there are plenty of videos and plenty of information that's out there to be able to give us more learning opportunities and to review some of the technology that you're going to see here today. And so I'm very proud of the 24th anniversary of this book as well. And this was really the first book that was, when we talk about digital, and I can see already that our screen is definitely, seemed to be a little bit yellow, so we'll have to figure that out. But I actually did a table clinic, a poster presentation at this meeting in, I think it was 1992, to introduce this book, because this book came out in 1993. And it was the first book that went totally from digital to print using a program that's still available today called Corel Draw. And so it was never on paper. There were never any drawings or anything on paper. It just went from computer to the print. So I've been involved in that digital workflow really forever, and I still use these images literally every day in my practice and when I create treatment plans for my patients. How common is this situation where you have a failing bridge and you're going to place 2 implants, and hopefully preserve the molar and be able to then restore this patient to the type of function and aesthetics that they need. So again, the concepts of where we are today in terms of technology, whether it's the digital workflow or it's just understanding where we should place an implant, how to assess an implant receptor site, we have to be able to understand how to utilize technology. And my email address is drgans at drgans.com. If anybody wants to share any more information after the program, feel free to send me emails. I try my best to be able to respond. But you see these incredible images. I mean, these are images that show the patient's mandible and maxilla and virtual occlusion. We can look here at what was underlying this situation with hopeless dentition. You can see that in the planning process, this was a case that was referred to me, and the laboratory was concerned that there wasn't enough inter-arch space. And so we're planning to do a bone reduction here, and we're going to remove the bone, maybe just in the lower arch, not the upper arch, to be able to gain enough restorative space. Again, we become the architects and the engineers of the oral cavity. But again, if you were building your office, you were building a new home, you're going to get a geological survey, you're going to get an engineer, you're going to get an architect, you're going to get architectural plans. But yet, when we do our cases, we tend to sometimes just do them on the fly, and we don't spend enough time in that diagnostic phase, or using some of the technology that we have to avoid complications. And we'll talk about many of these concepts, because the basic philosophy that I kind of came up with, along with all of the other wonderful colleagues in this organization many years ago, is to realize that our patients really are coming to us because they need teeth and not because they need implants. And so it's the tooth that we replace. And when I published this in 1994, I said, the concept was it's not just about the missing tooth, because obviously we're missing a tooth, but we're missing a tooth, we're missing the surrounding gingival tissue in many cases, or the amount of keratinized tissue, and of course we're missing bone. And so having the opportunity to be able to visualize everything that's missing, and knowing today that we have the capability to replace everything that's missing, that's where we should be, where the emphasis should be, to create that foundation so that when we place the implant will be stable. And we have to be able to know, is that implant stable enough to make the tooth? Because that's why the patient is coming to us. So when we take a look at these, and these happen to be any ridge implants, you can see the thread characteristics. This was an immediate extraction, immediate placement case. You can see that two of these are going to be screw retained, and two of these were angled abutments to be able to re-establish correct angulation. We don't have to necessarily do a screw access for each one of our implants, especially if the bone trajectory is not favorable. But this was also a case where we did a internal sinus augmentation at the same time, and we did immediate load. So the question is, how do you know that you can load a case like this? I mean, we can use subtractive radiography. We can do our little ping test to see if it sounds good. But the reality is, we need to be able to have more information to make sure that we know that an implant can be loaded the day that we place it. Now, in my practice, a vast majority of the cases that I do since 1989 have been an immediate extraction, immediate placement, or immediate restoration. And today, our tools and our technology is so much better between not just the implant body itself, but the implant and the connection and the ability to prevent micromotion has increased dramatically. And so we have confidence based upon our system, but yet we still make mistakes. So, I mean, maybe this implant was placed, and maybe we could take an ISQ value, and it may have been very stable in the sinus grafted bone that was placed here. I guess maybe that was the concept, to place it into the sinus grafted bone and not have any clue as to where the tooth was going to go. I mean, if you're going to hang your keys from it, and that may be an option. But obviously, it's not really the exception. I mean, there's a lot of cases that we can see that are like this on a regular basis. Now, Restoratively driven implant dentistry requires that we put that implant in a restorable place. So many years ago, I came up with a term called prosthetic gymnastics, meaning that the implant is over here and the tooth is over here, and somehow we have to be able to connect the dots, and that's usually under the auspices of our wonderful laboratory technicians. So they perform prosthetic gymnastics all the time, like a case like this. So this, to me, is not a success. However, maybe this was a traumatic injury case, maybe this was a cancer case, so it's hard to be able to really pass judgment. But too often, these are the cases that we see in everyday dental laboratory. So the diagnosis and the planning becomes very important. I see some of these cases online, and I have to kind of question some of the wisdom of publishing them online. When you see implants that are either touching or way too close, and you see these huge maybe monolithic zirconia with a tremendous cantilever, we are the architects and the engineers of the oral cavity. I can guarantee you that the people that placed this, or the person that placed these implants, did not measure ISQ values. I can guarantee you that. And so when, these are things that happen all the time. Are these implants worth saving? When you take a look at the peri-implantitis that exists here, these are questions that we have to ask, because as the population of our patients are growing older, I've been doing implants since 1982. So, I started when I was 12, very young. But when you think that we have patients that are going to come to us that are 20 years, have implants for 20 years, for 25 years, and you want to be able to see what's happening, this is often the case. So if you were going to make a decision, what is your decision tree in terms of, do I save this implant or should I take it out? So how do you know the real stability of that implant? Do you try to reverse torque it at this point? You tap on it? There are locator attachments on it. Do we keep that? So at what point do we make that decision, that it's not worth saving the implant and maybe we should be doing something else? Do we have a scientific basis to make that decision? And that's what we're going to talk about today. So of course, the background here is that the tooth position should always guide the implant placement. We have to make a decision about screw retained versus cement retained. That plays a very important role. And we can, in fact, be able to choose the abutment before we place the implants. This has kind of been what I've dedicated my career to be able to understand in advance exactly what we're going to do for our patients before we touch the scalpel to the patient. So, when we have the opportunity to place an implant, and we spend so much time with this soft tissue, to rebuild this soft tissue, to have such a beautiful emergence profile, but yet, how do we know that that implant is ready to be restored? This is a smart peg. First of all, are you using it at all, the ISQs? Okay. So if I asked you, do you ISQ, the answer would be no at this point, right? Okay, so we'll see what it is at the end of the day. So when we have the ability to be able to place this little device, this is called a smart peg, and we'll get into this in much more detail, we can understand the position, the stability of that implant based on resonance frequency analysis. It's going to give us an objective, scientifically designed measurement that tells us if that implant is within the realm of a value that we find acceptable to restore. Now you see this implant here has a multi-unit abutment on it. It has an angled abutment for screw retention. Now, there's a little bit of controversy of whether you can measure the ISQ value when you're looking at and not removing the abutment. This one goes down to the implant. This is an abutment. I'm not a big believer yet that we can measure true ISQ values on a multi-unit abutment. However, that's coming, I believe, soon. And so instead of spending so much time just on the soft tissue, we need to be able to understand, and I apologize for the color, I didn't test it before, so we are a little bit off, but we have to be able to measure the stability of that implant in a non-destructive manner. So yes, we can use a reverse torque test, but if your implant stability was kind of on the fringe and you end up reverse torquing the implant out, what are you going to do? But if we measure the implant stability quotient at that time, and we find that it is not totally integrated based upon the values that we'll talk about, we have a choice. We can leave it integrate for longer. So we have lots of choices if we have an objective means of measuring the stability of an implant. And we're going to talk about objectivity when we do our hands-on in a little while. Now, in front of you, you will see this box and then this unit, which is a beautiful unit that kind of looks like an iPad almost. And this is the new IDX unit. Excuse me. And so what is different between this and the older units that were available? And there is a tremendous advantage to the newer unit because it actually allows you to record data. And for me, that data is extremely valuable because what happens is that if you're placing an implant day one and you decide in your treatment plan that this was a two-stage approach and you're going to bury that implant underneath the tissue, you record a value. And then 2, 3, 4 months, whatever your protocol is, you uncover that implant. You want to make another measurement. And now you want to measure what the condition is of that implant on the day that you uncover it. And so having the luxury of being able to utilize a device that also can maintain a data set and tell you over time what happens to that value. Did it go from 69 to 70? Did it go from 69 to 58? Did it go from 69 to 82? What happened during that time? And so you can then start to make an educated decision about what to do with that implant or those implants, but also you start to build a bank of information. So if you have hundreds of patients over a couple of years, you're going to develop this big database showing you what's happening to the implants that you place. And let's just assume for a minute that you place 3 or 4 different systems, or you're working with a surgeon that's placing 3 or 4 different systems. And, you know, if you, are any of you guys surgeons, or oral surgeon? Perry, it's oral? Okay, so you have tons of referring dentists as well. And so you guys have multiple systems in your office. So let's say you have 4 different systems, just as a number. And now you have, you're looking at your ISQ values on the implants from A, B, C, D systems. Let's say over 4 years, you start to look at the systems and you say, gee, you know, this system is really, the ISQs are here and they're staying here. And this system, the ISQs are here and maybe they're going up, or this system, you know, they're kind of all over the place. You have some sort of objective way to be able to evaluate real important data. I think it's incredibly valuable. And this is where, you know, this particular device, and with the Ostel Connect, the software that goes with it, becomes very, very valuable. Not just because a lot of people think, you know, just like when you buy any piece of equipment, you may not think of all of the different potential uses of that equipment. And the reality is that there are many when you think about how important that data is, especially as oral surgeons and having a referral base of doctors. Because we can trace and track these individual implants over time. And, you know, look, one of my colleagues recently was doing a series of all-on-4 cases, just a generic term, not necessarily for any particular implant company. And they had several cases where the prosthodontic colleague, sorry, we're busy, but the prosthodontic colleague noticed that there were some problems with the implants, and a few implants failed. And, you know, when the surgeon went back to his records, he said, well, you know, I got 72, 76 ISQs. I get very high ISQs. Why should these implants fail? And so now you have, you know, something going on here that you know, can be uncomfortable. But the reality is, you have a medical legal entry in that patient's chart that said, when that patient left my office, I had a 76 ISQ. You know, 6 months later, and the implant failed, there's something going on. Maybe now we have further investigation. And so this gives us at least a foundation to understand what happened, even forensically. And in this particular situation, when we went back and looked at it, and we saw, because I was asked to consult on this, we found in looking at postoperative X-rays that when the prosthesis was created, it was fabricated, and we look at the postoperative X-rays, it wasn't seated against the implant. There was a gap with the abutment. So there was an issue with the fitting of the framework. So of course the implants ended up failing. So it had nothing to do with the initial placement, but it had to do with the restorative fabrication afterwards. And so without the ISQ values, though, it could be your word against somebody else's. Yeah, that implant was really stable. I got 75 Newton centimeters of torque on it. Torque value is a subjective measurement. And what does torque value measure? It measures the frictional resistance of that implant going into the bone at that moment in time. And once it's in, it's done. So we could give everybody ratchets here, which we will a little bit later, and you're going to be able to place implants, and we're going to see what kind of torque values that you get depending upon the drilling sequence that you use. So you could use 1 or 2 drills and then try to self-tap, and you can get tremendous torque because you have a very narrow osteotomy and you're putting this implant in that's wider. So yeah, you can have tremendous torque. But then if you measure your ISQ, you may not have a high ISQ because your implant may not necessarily be stable throughout the entire body of the implant, because that's what resonance frequency analysis measures. It doesn't measure the frictional resistance, it measures the stiffness of that implant in the bone. So it's a whole different mindset to understand what the value is that we have here. So of course the question is, do you ISQ? And that's going to be the question of this meeting, and hopefully this will catch on. Excuse me. So this is the older unit. You may have seen this before. And of course the smart pegs are designed not just one smart peg for every implant. They're designed so that you have smart pegs that fit the implants that you're using. Now you'll notice that when you look down the list that you may find that there are smart pegs that overlap 1 or 2 systems, and or 3 or 4 systems sometimes, and that is due to the testing of the fit of that smart peg, and there's a reason for that. But the reality is this is a magnetic device, and it really is a single type use device for this patient. So you're not going to be re-sterilizing it or anything like that. However, many clinicians will take an initial measurement. As you can see here, let's say the implant goes in and you say, okay, we're going to bury this implant, we're going to come back in 3 months and we're going to uncover it. Well, you could take this smart peg and put it in an envelope and put it in the patient's chart and go back to use it. That I think is acceptable, but not, it's not a general multi-use device. So all of these smart pegs, and you'll get a chance to be able to use them, are designed specifically for the implants that you're going to be placing. And then in the old unit, the only thing that we could get are the ISQ values. So it didn't give us, the tooth number. As you notice in the other IDX, we'll be able to place a tooth number. It didn't give us any indication of what happens over time because it wasn't recording that data. So it's a big step up from the older ISQ unit to the IDX unit that you have in front of you. And so I just want to make sure that that's clear because you may have seen the older unit. So when we're looking here, you can see that your assistant or yourself, whoever's doing this, you can go in, you can click on a tooth. You can actually input a tremendous amount of data about the manufacturer of the implant, the diameter and the length of the implant, and you'll be able to see some of that, I hope, on our units today. And the only thing that's still in common is the probe. And this probe, of course, is what gives us the information and bounces that resonance frequency off of the smart peg that's attached to the implant. So if we take a look here, we're going to place these Megagen implants. And one of the things that I just want to say about this implant, because it's very misleading. So you see these big, huge threads, and sometimes you see, some of the ads that have really even bigger threads, and it's very misleading because this is really not necessarily what this implant is about. The implant that you'll be using today does not have threads or nearly like that, although the body of the implant, as you can see here, the core of the implant may be the same. As you go to wider implants, the core stays the same, the threads get larger. But that doesn't mean that you have to use wide threads, as we will show today as well. So it's one of those implants that gives excellent initial stability, and we'll be able to measure that, and hopefully we'll be able to measure it in several different ways. So of course, my whole basis is going to be initially on the diagnosis. And when we have the ability to utilize 3D imaging, this is the essential tool to be able to get us to where we are. And when we look at the different views, and we can go through this really quickly, but the reality is that when you look at a tooth sitting in the alveolus, the reality of anatomy is different for every patient. And the reality of anatomy, when you look at this image here, is that our teeth tend to be on the facial or the buccal aspect of the bone. So we're not looking at teeth that are surrounded by this huge volume of bone. Now, how is that significant when it comes to measuring ISQ values? Well, if you place a smart peg into this, if you place an implant into this alveolus, depending upon where you place it, you're going to have thicker bone on one side and thinner bone on the other side. And so when you take your ISQ values, you're not going to just take one measurement. You're going to take it from the different position of the implant, such as you may go buccal and you may go lingual or palatal. You may go mesial or distal. And you may get different readings. And the reason that you may get different readings is because the bone density is different in that area. And we know that when you place an implant into bone, we never have 100% bone to start with. It's just not the way bone is. And so therefore, how can, we can all say, okay, well, I just drilled into that bone. That feels like D1, D2, D3 bone, D4 bone. That's subjective. How do we really know what that is? And so we can look at all these beautiful, pretty pictures, but unfortunately, even today, I've been involved with CT now for over 32 years, and I can tell you that most clinicians can look at these images and they still do not know how to diagnose and treatment plan in using 3D imaging software and CT or cone beam CT. I can tell you stories after stories, but you can see this area here where you can see that there's a thick buccal plate, a thick lingual plate, and often, especially in the posterior mandible, there may be nothing in the middle. And we may actually be able to see a case that resembles that today. So having this assessment is the first part of foundation to be able to assess the implant receptor sites. And once we understand the receptor site, we can then go forward to be able to analyze the bone quality, the bone density, and determine whether we're going to do an immediate restoration, whether we're going to do delayed restoration. And if you notice, again, look at the trajectory of the tooth versus the trajectory of the bone. So this is where I came up with the triangular bone concept that was first published in 1995. Look at this tooth here, sitting way above the alveolus of the mandible, which is why we may need to do a bone reduction, which the bone reduction template is also not only another one of my concepts, but one that I introduced at the AO meeting many years ago as a clinical innovations, and it didn't win. So, true. So, but look at the alveolus, and you can imagine if we could do an ISQ value on real teeth, it would give us a whole another perspective on the periodontal disease going on with our patients. But we do not have that technology yet. Maybe the guys from Ostel can work on that. We can measure the ISQ value of real teeth. That would be something. So understanding, look at the thickness of the cortical plate. So you see the cortical plate on the lingual is much different than the cortical plate on the facial. So why would we think that we're placing an implant into that area that we would have the same stability of the implant on the lingual and on the facial when we clearly have a thicker amount of bone or a denser amount of bone on one side than the other? Is the ISQ a device that would pick up that difference? And I believe it does. And so the reality of anatomy for all of these patients, for these implant sites, is going to be different for every single patient. Every single patient has their own reality of anatomy. And so we have to be able to then utilize our software, position the implant where we best think we can restore it based upon the length of the implant, the diameter of the implant, but also if you look at, again, the density. Now, we know that cone beam CT does not really give us true Hounsfield units as regular CT does, but we can use our eyes to look at the difference between white and then all of the other layers, levels of gray. And so you have, with your own eyes, we can do what we call relative density in being able to position that implant within that area. And once we have become the engineer and the architect and we can place that implant, we have to then be able to know, if it's going to be, what happened there? If it's going to be stable. Okay, so the initial part, the background here is that we need to have the diagnostic capability, which gives us a tremendous amount of power to be able to then make a plan. Now, this plan, we have the luxury today with all of the digital communication tools that we have. We can evaluate this on all the different levels with our referring dentists, with our laboratory partners, with the patient, with everybody that needs to be involved so that we can then execute the plan. The problem is the best laid plans don't always come to fruition, and we don't always know that we can accomplish what we want to accomplish. As an example, if we're going to do immediate extraction, immediate placement, can we in fact position the implant perfectly within that bone and then get enough stability that we can restore that case? And we know that before we touch the scalpel to the patient. So just a quick little video. This was, you know what, let me see if this will play. This was from, believe it or not, this is the first AMIS implant meeting. Whoops. Will this play? Oh, it won't play. Okay, well, we'll skip that. I'll come back to that later. But that was the first implant meeting in 1995. And basically, I'm saying the same thing I did 22 years ago. I guess I have a suntan now. This is definitely the projector. I'm sorry. So the International Congress of Oral Implantologists, the ICOI, they came up with their position paper several years ago. I was one of the authors on that paper. And, what was important is that we looked at all of the different things about 3D imaging. And the recommendations at the end was that, this requires a specific skill set. This came out in 2012, and we're still not really teaching clinicians how to diagnose and treatment plan in 3D. But there's also one thing under protocols that says 3D imaging technology does not supersede sound, surgical, and restorative prosthetic fundamentals. So we still have to position implants where they're restorable in good bone. Just because we're using technology doesn't mean that we supersede, our normal judgment. So very quickly, I want to go over the three types of guided surgery. That's in our book and several other articles. And what we're going to do today is under the category first of diagnostic freehand. Now, diagnostic freehand means that we're going to place the implant freehand, but all of these are based on cone beam CT data. So obviously, if you're placing it freehand, you have much more potential for deviating, no matter how good a surgeon that you are. Template assisted means you're going to use some sort of a template, and full template guidance is where you're going to use full template guidance. You're going to not only drill through the template, but you're going to be able to position the implants through the template. So we're going to do two hands-on today. One, we're going to do diagnostic freehand, and the second, we're going to do somewhat template assisted, and we'll see how you guys like that concept. So if we look at what we have, the protocols in our book, diagnostic freehand, you're going to assess the site. You're going to be able to then position the implant based upon whatever software that you're using, and you're going to then place your implant freehand. So that's diagnostic freehand. That's what we're going to do in the first hands-on. Whoops. Why is this skipping ahead so fast? The second is template assisted, and that means that you're going to use a template. It doesn't matter what type of template you're going to use. whether the lab fabricated it, whether it's fabricated from your CT-derived data set. But you're going to go in, and you'll notice that we're raising a small flap. Now, in my practice, hardly any of the procedures that I do, that I'm involved with, are flapless. And we'll talk about that because that's going to be our first hands-on experience today. But here you can see that we're replacing the implant. We have a template, we have a cylinder, it's guiding the drill. And hopefully it's guiding the drill so it doesn't hit the roots of the adjacent teeth. Now, back in the day when we first started doing CT-derived templates, we actually had a template for each one of the cylinders. Today, of course, we only use one template. But back in the day when we first started using stereolithography and 3D printed type of templates, that was the state of the art. Full template guidance is where we're going to drill the osteotomy. We're through the single template, and then we're going to, using some of the hardware, we're going to position the implant through the template. I think, Scott, you have the kit from the R2 gate kit here too?
Yes, sir.
Yeah. And so in order to be able to do this, you have to have the cooperation not only of the design of the template, but you have to have the carriers from the manufacturer that match your implant, so that you can then place the implant with confidence through the template. So that's the special carrier that you need. So now, if we're going to place these implants here, and we're going to position them through the template, and the goal here is to then make an immediate restoration, how do you really know that those implants are stable? Because of the torque value? Well, that's the way most people have done it in the past. We're going to give you some other ways of doing it today. So with the MegaGen system, there's a new concept that came for this particular system called R2 gate. And this is not yet really available too much in the US, but we're trying to get more people involved with doing this. And again, it's another one of the ways of being able to do full template guidance for different variety of cases. But the idea here is that you have simulation. And what we're going to talk about a little bit later is what I think is simulation that we've never been able to experience until now, until the last like 2 years even. That to the major population, where we're going to be able to simulate the case totally before we ever touch a scalpel to the patient in ways that I dreamed about when I first started talking here at the AO meeting in 1993. So we are like really at that point where we can do some really cool things. So when we talk about the types of templates, again, this becomes important very quickly to show you that we have the tooth-borne template. Today we're going to be dealing with fully edentulous cases, so that doesn't apply. We have a bone-borne template, which will apply for today, and this was one of the first types of templates that was done with guided surgery. But most of the time when you have a bone-borne template, we're going to need an anchor pin to anchor the template over the bone, as you see here. Or you have a mucosal template, one that will go over the soft tissue. So the question is, how accurate are these templates? And that's another subject entirely. But I believe that the mucosal template is probably the least accurate of all the templates because there are too many variables in terms of that soft tissue and stabilizing everything. So one more article I think that's important is the AAOMR, the American Academy of Oral and Maxillofacial Radiologists. That's the specialty of the ADA. And I was also in 2012, so this is already 5 years old, and their conclusion was that the AAOMR recommends that cross-sectional imaging be used for the assessment of all dental implant sites, and that cone beam CT is the imaging method of choice for gaining this information. So this is actually supposed to be yellow, so we're definitely off in the color. Now, this was very controversial 5 years ago because of one word, and that's this word here, all. And they wanted us to retract this article, but we stood our ground and we didn't retract it. So this is really important because it deals with state of the art, or it deals with standard of care. So where are we? And we have a problem though, and this is my personal opinion, in terms of guided surgery, that it's flawed in one aspect. If you put two dentists in a room, you're going to get at least 3 different opinions. So we don't have any real concrete way of agreeing on where to place the implant within the receptor site. However, what we can show today is that we will have an objective way to say that yes, that implant is stable. Yes, that implant is stable enough to load. Or no, that implant may not be stable enough to load. So although we may not have an agreement on where the implant should go in the receptor site, and we certainly do not have another objective way of measuring implant stability using the ISQ values, we will have an objective way that we can all agree on, because it goes very simply with the technology that is now backed up with, I believe, over 800 articles in the literature. I mean, how do you argue with over 800 articles in the literature? Wow, that's really going to be way off in color. So I want to, we're pretty much on time. So how did we get here? That's the end result, and of course it looks horrible with this projector. I'm sorry about that. But this was done in a diagnostic freehand manner, and we're going to show you how we do that, because here's a patient that comes in like this. Now, here I am, one of the guys that is thought of as a guru of guided surgery, but yet I realize that still 97% of people do not use guided surgery. And so, you got to join the club at some point. And you have to be able to understand, if we're not going to use guided surgery, but we're going to use diagnostic freehand approach, how can we maximize the result? And so I thought of a couple of cases, that resemble a teaching exercise that we could review. So as an example, if we're going to place implants and extract all of these teeth here, and we can do immediate extraction, immediate placement, and immediate load, we want to be able to, I think my videos are not working. We want to be able to assess the anatomy. And by the way, this patient already had 3 implants in the posterior left quadrant. And what's nice is with cone beam CT, and when we go back and we look at cases that we already did, we can start to assess, did we get the implant exactly where we planned it? In this case, the answer is yes, even with this big concavity in the posterior mandible. So if we take a look at the 3D planning, this is a reconstructed view of the patient's mandible. We're going to extract the teeth in white. The purple teeth here are going to stay. Those are supported by the 3 implants that were pre-existing. The yellow projections, this is what I like to do. I like to be able to project above the occlusal table so I can see where the implants are going to go. And then with this particular software, we can do virtual extractions, and we can make the teeth disappear before we remove the teeth in the bridge, if there was a bridge work. And so we can visualize the bone. And in this case, I positioned implants that were parallel. I'm a prosthodontist. I like to get things parallel. Gee whiz. Parallel if possible. We're very sensitive today. We want to be able to, of course, avoid the anatomy. And we're going to try to position these 5 implants. And you can see that that's a residual root here. So the question is, can we do this without guided surgery? What is going on here today? We can, in fact, be able to utilize the different software to be able to visualize the patient's anatomy, and it doesn't matter to me what software that you're using. But the reality here is that most people are not using surgical guides, so we're going to do this in the diagnostic freehand approach. So the first thing we're going to do is we're going to take out one tooth. By taking out only one tooth, we keep our perspective about the adjacent anatomy. And so having that with our cone beam CT data, we can position the first implant, and then we can, here's a residual root here, we can go and position that implant. None of my videos are working all of a sudden. And we're going to put a titanium sleeve and screw, which we're going to do something a little bit similar to a little bit later. There you see the residual root. We're still going to keep the other teeth. We're going to position the next implant. We're going to be parallel, and then eventually we'll get all 5 parallel, or as close to parallel as we can. So this was all done diagnostic freehand using the cone beam CT data to know where the implant should go within the extraction sockets. The question is, how do we know we can immediately load this? So we're going to go in, we're going to measure the ISQ values, and we'll show you that in a little bit. We're going to use our rubber dam, we're going to create our temporary, and at this stage, this particular case was done before the IDX came out, and the concept here is that this is acting like a tuning fork. So you're placing this smart peg on top of the implant, and it will act as a tuning fork to send the magnetic resonance and that frequency back and forth with the probe and come up with a value that will be measured now on your IDX unit. And so we can see it here, and we're measuring the smart peg versus the probe, and we'll come up with a value. Now, the values that we've seen in all of the 800 plus articles in the literature revolve around the ISQ scale, and you can see that it goes from low stability to high stability. And there are some subjective concepts in this scale. In other words, if you were doing one single implant, to me, the stability quotient needs to be at a much higher threshold than if you're doing 4 or 5 implants and splinting them together. So if you ask like Peter Moy or some of the other KOLs that have been talking about this technology, they will tell you that they make some subjective decisions based upon their clinical experience, but at least you have something to write down in the patient's chart. So here you can see full splint, partial case, single case. So when you're dealing with a single implant, now that single implant could also be between 2 natural teeth. So it's kind of protected. Or it could be a standalone tooth and there's a posterior edentulous area. You have to look at that a little bit differently. So the ISQ values that you may see that people have printed or published in the literature talk about the scale that you see here, but those numbers have to be taken in consideration with the actual case that is taking place. Does everybody understand that concept? So when we're looking at ISQ values of over 70, to me that's pretty much a value that we can hang our hat on that says, yes, we could load that implant the day that we place it. That's a high enough ISQ value. Now what's going to happen to that ISQ value over time? It may go up, it may go down. It may, as we know, the bone will remodel, especially during the first 4 to 5 weeks. So the question is your philosophy to load implants or not? When you have more than one implant and you're splinting them together, that of course adds a little complexity to the situation. And so when you have so much scientific evidence that tells us that these values really do have an effect on the outcomes, what other device do we know of has that many articles in the literature that are scientific, that are evidence-based? So when we take the measurement, again, we can measure this from different angles. We can measure it from the mesial, from the distal, or from the facial and the lingual, or from the occlusal. And we may get different values based upon the surrounding bone. And we're going to play with those values in a little while. And you may come back, or here we see what we're measuring from a different position here. And there should be, let's see if this, oh, you know what, maybe this is not. Here we go. So that was the original sound, kind of like a heartbeat, when you have your EKG. So I call that the sound of confidence. When you hear that and you come up with a number like 85. So here's our temporaries on that particular case. We did immediate extraction, immediate restoration. At that time, we were still using cotton. We don't use cotton anymore. Now, when you look at the restorative phase and you see 5 implants that are pretty parallel, again, this was done freehand. The soft tissue is starting to fill in. We have the values that we went in with. We removed this at 8 weeks. We take our impressions. So now we know that we can do this. And again, I apologize for the projector. We were originally supposed to restore this in 3 different ways. That didn't happen, so we ended up just restoring it with a conventional fixed restoration. So this would be a normal type crown and bridge type case that you can see on 5 abutments. The soft tissue is starting to work in, and the color is definitely way, way off. But the result ended up being very nice for this particular patient. So why did we have the confidence to be able to restore this patient immediately with a temporary restoration? And why we're able to know the timing, and again, I apologize for the staining, because certainly we definitely did have some staining on this particular case because of the cosmetics of this particular individual. But let's take a look at what happened with these implants over time. So we have the implants 1 to 5. The day of placement, we started with 68, 76, 74, 77, 82. So now we have, at that time, we were writing these in the patient record. Today, with the IDX machine, with the device, we can go ahead and we can enter that data into the IDX. It does it automatically. And in fact, you can enter, as I said before, the diameter and the length and the manufacturer of the implant. So you have a tremendous amount of data. At 8 weeks, when we removed the temporization phase to start taking impressions, the number 1 implant went up to 70, number 2 went up to 78, number 3 went up to 80, number 4 went up just 1 to 78, and number 5 went to 82. Now, the numbers don't have to change. If you started at a high number, there's nothing wrong with staying at a high number. It's what happens if it starts going down. And we can look at that over time. So we had this patient come back at 6 months, and we recorded the values again. We removed all the prosthesis, and the number 1 went all the way up to 76. This went up to 80. This went up to 80. This went up to 80, and this one stayed at 82. So for this particular case, we can look at what happens over time. Now, we're not going to necessarily be tracking all of our implants through many, many, many months. That's not necessarily what we do in private practice, especially. But for the oral surgeons that are here, I think having this data to be able to enter it into the IDX device and looking at the Ostel Connect is a huge, huge data bank of information that ultimately will help you as practice better implant placement and understand the survival rates and understanding maybe what happens down the road with the prosthetic reconstruction. Can we do this with torque? Of course not. We can't now start measuring torque again, because remember I said the torque is the frictional resistance that moment of time when you're placing the implant in the osteotomy. So we're going to measure torque in a little while, but when we come to this situation where we have to look at an implant over time and knowing when to load it, these values that we get with our ISQ, with the resonance frequency analysis, become very important. So, during the summer, I received some email blasts. You guys may have received it as well, because there's one particular group that's out there that runs all of these courses that you may have seen, and they were running an ad which I haven't seen recently. But they have many other ads that they've been running. And let's see, I was talking about this here. Brain-guided low-cost implant surgery for every practice. I can't make this up. And it's about this online education course. And it's about the fact that you don't need expensive digital tools. What every general dentist has to learn, why every general dentist has to learn brain-guided implant surgery and brain-guided versus cone beam guided surgery, which works better. So basically, he's implying that if you're using sophisticated software, that you're not using your brain, the computer's making the decisions. And of course, that's totally wrong. Which equipment do you really need? A lot less than you think. In other words, you don't have to invest in any of this high-tech equipment. You can start placing implants with no money down. These are the ads that I was getting during the summer, so it kind of really got me a little bit angry. And around the same time, I had an interesting case that we're going to be sharing right now. So this is what he really said. Brain-guided versus cone beam-guided surgery, which works better. Why you never need expensive technology to get started doing implants. And this is what this guy has sold out courses. It's amazing. And it kind of goes with another maybe sold out course that we'll talk about in a moment. So, for instance, if you take a look at a situation like this, do you think if you took a periapical x-ray that would show that condition of that alveolus? Absolutely not. You need to have a three-dimensional assessment to be able to then plan properly. So let's take a look at this particular case. So this is a perfect case to talk about brain-guided implantology. But I'm using my brain. The guy that started this case did not really use his. This guy took a weekend course. You can't make this up. He took a weekend course, and that course was to be able to place mini transitional implants. Because this patient did not have a lot of money and wanted to retain this completely loose existing lower denture. So of course, we're going to place 4 mini transitional implants in this particular area here, and he was going to do this for this patient and charge very, very little. He never did this type of implants before. He took a weekend course, and this is the first time doing the case. So, what would you treatment plan this case to be? You could do maybe 4 implants, all on 4, if the patient had the finances. So you had to think, what would your treatment alternatives be for this particular situation if this patient came to you? 4 implants and an overdenture? Well, this is pretty much what the patient wanted, but he wanted to use his own denture. 5 implants and a fixed hybrid restoration? It's a possibility. 4 mini implants for an overdenture. Well, that's what he was sold, and that's who we went to. And then, do you do this flapless, or you do it with a full flap? So that's really the question. Do you do it flapless, or do you do it with a full flap protocol? So I'm going to give you this for now. You can just hang on to it. You're not going to do anything with this one. I just want you to see it. So this is from a 3D printed model, and I had them overlay. This is this case. I had them overlay the soft tissue. And so take a look at it and tell me, would you do this flapless? Would you do this? I mean, this is basically the presentation. You're seeing what it looks like in the mouth. This is what was presented. The patient went to this dentist, and he started placing the first implant, mini transitional, first implant. The drill broke. Slipped off the lingual, broke into what he thought was the bone, and broke in half through the flapless approach. And then he referred the patient over to an oral surgeon. The oral surgeon actually said, don't do anything, just leave it alone. And we'll think of another protocol to do for this patient. So the patient lost confidence in both the general dentist and then the oral surgeon for not coming up with a solution, and eventually found the way to my office through my wife, a friend of my wife's. They did take a cone beam CT, which I'll show you momentarily. But when we looked at the case and we actually used our brain, we decided that there was really no way that this particular case could be done flapless. So let's take a look at how we do our cases. So you see the tissue covered model. This is what it looks like without the tissue. Can't make this up. That's what it looks like without the tissue. So, no preoperative cone beam CT, flapless surgical protocol, first time using the surgical kit. The proposed 4 mini implants to attach the existing denture. The first drill immediately broke into the bone immediately. And again, I apologize for the color. It's a little bit too red there now. But there's the drill. So when I saw the patient, we opened the patient up and found that the drill was broken off into that lingual vestibule. Now, we all know that there could be very severe complications if you drill accidentally or drill through or perforate through the lingual cortical plate. Fortunately, it didn't happen for this particular patient. But some other things were quite interesting. When we look at this situation, and you have it now in your hand, so what could be a better, remember I was talking to you about simulation? We have the ability today, at a very low cost, to 3D print our mandibles or maxillas and have actually the bone in front of us, not only to plan our cases, but to show our patients and to investigate and to utilize for the prosthetic reconstruction. Where it used to cost hundreds and hundreds and hundreds of dollars to produce these, you can produce them now for dollars, literally, if you have your own 3D printer. So if we look at where the bone is over here, and we look at the shape of the bone, that's what you're looking at. So that's what you're looking at. You have it in your hand now. That's the shape of the mandible. Here's the Swiss Alps, right? You wonder how the patient could wear a denture. And this is the patient was in pain every time the patient bit and chew. Look at the left side, and you have it in your hand. You see where the mental foramen is on the left side. You can see where the mental foramen is on the right side. So the nerve is right on top of the bone. Having the nerve right on top of the bone becomes problematic, obviously, with the denture. So it would be great if we actually had an implant-supported restoration so that, do you need me?
I was just going to give you another water.
Oh, no, I have. I still have. I'm still nursing a cold, so that's why. So, whoop. What did I just do? Stop. So the implants would be a great idea to prevent the pressure on the nerve here, especially on the right side. Okay, so now you see what we got. You see it in front of you. If this was your case, what would you do now? What would you do now? What do you think? If the patient still wanted 4 implants for an overdenture, how would you treat that case? You have the bone in your hand.
Get a prosthetic overlay or plan and do prosthetic with your treatment plan.
What would you do with the bone?
That would definitely be an abdominoplasty to keep that down the table bone.
Okay, so you would have to reduce the bone, flatten it out, and place the implants. How simple, easy you think that process is? Is that fairly straightforward in between the two symphysis? I mean, in between the two mental foramen in the symphysis? Sorry. Right? Seemed pretty straightforward. Well, if it was that straightforward, I wouldn't be showing you this case. So let's take a look. Let's take a look at what really happened here. So when we start to look at the 3D planning, we said, okay, well, look, we have the nerve here. We can see that there was maybe a long anterior loop, so you may want to stay away from that. Here's the left side. And it just so happened we could place 4 implants that were 4 millimeters in diameter, not 1.8, but 4 millimeters. And that might be a better spread to support an overdenture and get the pressure off of this nerve area. But when I was looking at this case, I saw something that was really intriguing, because the 3D model, the reconstruction is really nice, and now you have that in front of you. But if you look at this area here, you start to see that the thickness of the bone here and here, you got the genial tubercles in there, and you can see in this area, look at your eyes in the areas of gray, and you can realize that in the middle of the symphysis, even though it looks pretty wide, perhaps there's no bone there. So let's take a look. Here's the bone reduction, and this is a concept that I came up with many, many years ago, which now has become routine because of 3D printing. But when I came up with that concept, the companies didn't want to do it because it required 2 or 3 different software to be able to create it. Even today it does. So it's not a money-making operation. But being able to flatten the ridge is a really good concept. So this is a concept that I came up with years ago to make a bone reduction template that fits over that area so we can flatten this bone out and then place implants. But you see, when we flatten the bone out, the bone is flat. And now we can make a secondary template to position the implants because we have flat bone and now it's wider. Well, in this particular case, that wasn't exactly what happened. In this case, when we went in there and we looked at that knife edge ridge, and by the way, we knew this in advance of reducing it, we have the 3D cross-sectional images. Now, I'm not one to expect you to be able to look at even these images smaller, so let's bring them a little bit higher up and zoom in. So if you take a look at the lingual cortical plate here, and you look at the buccal cortical plate here, oh, I forgot to tell you, when the oral surgeon ordered the scan, they got a great big field of view of the maxilla. Unfortunately, they cut off the mandible, which was the region of interest. So you can see the inferior border of the mandible is cut off. That's why your models are flat, not because we wanted it to sit on the table. So now you can see that here's a 4mm implant that engages the walls, but what happens down here? There's nothing to grab because there's no bone in between the buccal and the lingual cortical plates. Here's another slice, and you can see the gray here and the gray here is the same. Look at the density of the bone here, but the density of the bone here and here on the buccal and lingual, but there's nothing in the middle. The intermedullary bone is very sparse. Hello? I run out. So here is the area where the genial tubercles are, and you can see again this red area. Look at the peak of bone up here. That's the peak. So you want to flatten this area out, and you flatten it out. What do you get? You get nothing. You get the Grand Canyon. And then, of course, we have these other areas of whatever they are. They're vessels and other stuff that's in there because, again, we don't have 100% bone when we think we are, even in the anterior symphysis. So, we are really skipping ahead. So, okay, so here we are. We open it up. We flatten out the ridge. And that's where the hollow is. We basically have granulation tissue in there. We have just stuff. So imagine if this guy actually had a flat amount of ridge and tried to place a 1.8mm implant in the anterior symphysis, it would have dropped into nothing. It would have been space. So let's see if this should play. Good. Okay, so let's take a look. Ooh. So here's the anterior symphysis. We don't expect it to be like that, but yet that's the way it is. So here we are scooping out just with a curette. We're scooping all this stuff out. So there was no bone in an area where normally we would think that there's bone. And so looking at this again, going back to the architectural engineering plan, I said, can we actually get implants in, stabilize these implants? And so using our segmentation tools within the software, we can actually place an implant here, 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 and here. And that's what you guys are going to try and do today. So we're going to place the implants on a case that we really did. And we'll see if you can mimic the case that I'm going to show you. And you can see that we have the 4 implants. They're not tilted. They're placed to support an overdenture. And look at the cross-sectional view. Here's the cross-section. There's no bone here. So trying to do this freehand is not so easy. Trying to do this with a template is not so easy. It's because we're missing bone, and you have to be able to get the drill into the right position. And then the question is, how do you measure the stability of the implant? And so this is where we have to have the combination of the diagnosis, the treatment planning. So here's that peak of bone. We're going to flatten all this out like this. And then we're going to position the implants. So here we placed Megagen implants. These are 4.0 any ridge implants from IDS. And you can see that they're positioned exactly pretty much as we had planned them. with the cone beam CT. So this is diagnostic freehand, or it could have been template assisted. Not going to tell you that at the moment. But you can see that the implants are buried below the crest of the ridge, as we would like to have this particular implant anyway, because this is a true platform switch implant. We measure our ISQ values at this stage, and now we have our decision. Are we going to place our componentry on top of this? We're going to do healing collars as a one stage? Or are we going to graft and bury this as a two stage and come back later? Or are we going to do an immediate load if we were going to do an all-on-4? But we know that we're not going to do that. For this case, it's going to be an overdenture. So what would you do in this case? Would you put healing collars on and reline the denture, or would you bury it? What do you think? Have them submerged and then come back? How long would you wait? About 4 months? Anybody else?
In case like this, I would put 6 implants. This is like, I think, like Brennemark in the 80s said this is the classical case. You can put 6 implants and make a bridge in it. And in case like
Well,
work only 4.
let me step back. The patient couldn't afford a fixed bridge, so that was a financial limitation. Number one.
So you can put 4 and you can put
No, but
these 2 provisional implants.
But here's the problem. You can't put 6 implants between these two mental foramen. There's not enough space. How would you do that? There's an anterior loop here as well that's significant on the right side. So it's nice to be able to say that, but the reality is that you at best, 4 implants. Now, could you do it as an all-on-4 with tilted implants? Yeah, that would be an option. But this patient did not want a fixed bridge, couldn't afford it. He wanted something just to maintain his existing denture. But if you can do it, if you think you can do it, you can drill 6 osteotomies if you want, because that's what we're going to do next. And we'll go through that. So here's the case after the bone has been flattened. And you can see where the mental foramens are. Ooh. Be careful. So you can see where the mental foramens are on either side. And let me guide you through the process. So here you can see 1, 2, 3, 4. The anterior loop came out to about here on this case. So could you squeeze 5 in? Yeah, it's maybe possible. Maybe, but 4 seemed to be what we needed to do for this particular patient based upon his financial needs. And so the question is, at this point, do we do this as a one stage? And let's say that we have the values in this particular case, they range from 68 to 72. That was the range of the ISQs on these implants. And so the bone quality was okay. Based upon the aggressive thread of this particular implant, but we still have this huge void here and here around the implants. So we filled this in with our bone grafting material. We covered this with a PRF membrane, and then we closed this and let it heal. And we let it heal for about 3.5 months. So that's what we did for this particular patient. And this is what it looks like at 3 months. So 3 months, we don't have a lot of keratinized tissue to deal with, so we would like to have more. But the question is, do we have predictable results? Yes, we can if we use our brain. And our brain was used, the computer did not make the decisions for us, we made the decisions. And we went in and we started measuring the ISQs. And now we have full bone covering these implants. You can see now we're placing the healing collars just to open up this area. We measured our ISQ values at this stage, and every value was 76 now, 76 to 78. So we have stable implants. We're not expecting these values to go up to 80s. We just want them to be stable. As long as they're over 70, 72, I'm very happy with that. And I'm happy especially because we're going to deliver what we wanted for this particular patient. So each one gets recorded again, and it gets recorded in our IDX device, and then we can compare it. And in this particular case, we used 4 Rhine attachments, which are kind of like locator attachments for this particular situation. And we can see that we have good parallelism, and this was very retentive for this particular patient's denture. Could you get 6 implants in here? I don't think so. 5 maybe. But again, this was supposed to be an overdenture for this particular patient. So now, let's talk about what we can do for our hands-on component today. But here's what we're going to look at with the IDX. So if we look at over time, as an example, here's what we see for tooth number 30 on a different case. You can see the dates. July 13th, 2016, it registered as an 80. September 6th, it registered 85. So just 2 months later, or 2.5 months later. And so, no, about 2 months later. So we can measure this change objectively over time, and within the Ostel device, the IDX, there you can see some of the scales, and you can see how visually on the graph, how it changes over time. Tremendous amount of data. And I don't know how you can do that with any other objective means. Because as you'll see later, when you guys play with it in a few minutes, that this is totally objectable. So, totally objective. That means that all of you guys, when you place your implant and you measure your ISQ value, you can trade off with anybody else on a different machine, or the same machine, I should say, and you're going to get the same value. Whereas when you torque these implants in, as we'll do in a little while, some of you guys are going to say 35, some of you are going to say 50, some of you are going to say 75, some of you are going to say it's off the chart. It's totally subjective. Okay, so the question is, can we do better? And the answer is, yeah, because today, if we really wanted to, we could 3D print our mandibles or our maxillas in advance of the procedure. And that's what you have today. You have a 3D printed mandible that was created from, that was now created from a mold, so we can mass produce these. Because the material that we use for 3D printing is not really drillable. You can't really drill into it and get, a real ISQ type value. And so when you look at this is what a 3D printer would look like. We have the ability to be able to go in and be able to, this happens to be the Formlab 2 printer. This is a $3,500 printer that you can, yeah.
Sorry to interrupt, but they're about to break down.
I'll give-
Do you own your own printers?
Yes. Yeah, I've been printing for years, and certainly was one of the first people to start using stereolithography many years ago. But it hasn't been until recently that the printers are now, at the level of price point and accuracy. So these are what you have in front of you are molds from a 3D printed mandible, and so we could make many of them and in the right consistency for drilling. So this is what it looks like. This is what it looks like when it comes off of the print bed. And you can see that the mandible is sitting on these little structures, and that's kind of like a sprue, like we did with castings in the past. And it actually in this machine gets printed upside down, as you probably will see in a little while. So it doesn't come up like that. So that's the actual case that we're looking at here. You can see where it kind of looks melted in this point, but that's just right out of the machine before you put it in the alcohol bath. And then if you look here, you can see that I've printed a mandible, and a bone reduction template, and then a surgical guide for a different case. So I can have everything printed depending upon the size of the print bed, and be ready to rock and roll. But of course, the templates are only as good as your plan, and so this requires some knowledge on the software and the hardware to be able to do this. And you see back in the back here, that's your alcohol bath. This gets cleaned off in there, and that's how we got to this point. So here we are with the mandible that you see here. So this is the real case. I wanted to have them fabricate a couple with the gingival tissue over it so that you could look at that and think about the fact that this guy did this flapless. Now, I do almost nothing flapless because of a number of reasons. But number one is not because of the visualization, but it's because we're always manipulating the tissue. We're always adding bone or moving tissue from the palate to the facial. And so, trying to get rid of keratinized tissue with a tissue punch, to me, is throwing away some valuable real estate. And in this case, we needed to flatten the ridge and do bone reduction. So this is the mandible that you have without the soft tissue overlay. And you can see the knife edge ridge. There's the mental foramen. You can see how large it is. And you can see how thin that ridge is. So I thought about having people do a reduction template here and everything else, but obviously that would have been a lot of work as well, and we decided against it for this particular hands-on workshop. But even when you look at this mandible, now that we've reduced it, so here you see before and after, now it's reduced, and it's reduced at the level. We couldn't reduce it anymore in the posterior because we're right at the mental foramen. So you have that limitation, anatomical limitation of where the nerve exits out the mandible. And so what we need to do is we need to then, in our minds, understand the three-dimensional picture of where we're going. Understand, in this case, we're not going to have a denture to use as a template. So we're going to do this freehand, and I want to walk you through this. And Scott's here to help with some of the drilling sequence because we may play around with it a little bit because, again, this is not real bone. But we can see where the mental foramen is here again. And so, the question is, how far in front of that mental foramen do you want to be, and where do you measure from? And we know from the cone beam CT data that there was an anterior loop as well, much smaller on the left side. And this should play. There we go. So this will give you a little bit of a background of the any ridge system that we're going to use. So you see, this kind of is misleading with these huge threads, and it kind of maybe puts people off. But that's not really the entire crux of this system by any stretch. This is a true platform switching type implant, and I hardly ever use threads like this. That's only for like type 4 bone. So the concept here is of the platform switching, that it preserves the cortical bone, less stress on the cortical bone, enhances initial stability. That's one of the reasons that we're using it for this program. You can see the difference. It's made, the threads are made for the different types of bone. So the big threads are really only used in D4 bone. So you can see it says less insertion torque, minimizing the compressive forces. So you don't want to just ratchet the heck out of this particular implant. And you can see that the neck is inset from where the threads are so that you can get a true platform switch, and also that gives you more prosthetic space to work with. We're not doing any prosthetics, but it's a single prosthetic connection regardless of the implant that you're using. So it's a true platform switch type of concept. So in order to be able to measure ISQ, we need to use an implant, and that's the implant we're going to use. So here you see that in order to have a platform switch and get bone growing over this area, you also need to have a collaboration between the connection and the design of the abutment. So you can see this like a reverse S-curve here of the abutment becomes very important. And then it's a question of where you're going to place that implant versus the type of bone that you have. And we're going to bury this implant about 1 millimeter below the crest of the ridge. And we'll see if we can have differences in the torque values and also the ISQ values. The connection here, which we're not going to really deal with, is again a true conical connection and allows you to have a variety of different abutment choices. So if you take a look at your drill kits right now, we can see that there is a drill sequence that's going to go from left to right. And so what we're going to do is on the mandible that you have, and don't start anything yet. We're going to go through this. And Clements, you may want to like video from that side when we do that. And we can put the lights up a little bit. So what we're going to do is we're going to start with the lance drill, and then we're going to make our way to the right. And I think we may first start ending with the 3-3, and we'll see how that goes in on your first sight. The first sight's going to be a little different, so here we are blowing this up. So the lance drill is basically to penetrate the bone. You have a 2.0, 2.5, 2.8, 3.3, 3.8, and so on. The implant size that we're going to place is 4.0. The only problem that we were limited in the dummy implants is that, when I say dummy, that means that they're not less intelligent, they're just not real implants. But they're only 10 millimeters long. So we'll see, can we get good stability even with a 10 millimeter implant, and can we measure this on our mandible that represents the real clinical case? So we'll learn together. If you notice that in this drill sequence below here, there are also depth-specific drills. So we can utilize the depth-specific drills instead of necessarily going across this way. If we're going to place a 10 millimeter length implant, we can go to the 10 millimeter size and then also go left to right. Here you see the markings, so you can tell where the length markings are. So we're going to be placing a 10 millimeter implant, but in some cases I want you to drill probably to 11.5 and even a little bit longer to get through into the bone that we want to get into. So 1, 2, 3, 4, 5, or we can go across this way. So this is the system. This is 4.0 by 10, exactly what we're going to be using today. And this really tells a lot. And what's kind of missing here is that we don't have an ISQ attached to it. Now, what's interesting is if you go over to the IDS booth over there, you'll notice that they have also a device that measures implant stability quotient, and they call it the Mega ISQ. That has been sold to MegaGen users, and it is made and fabricated by Astel. So it's not a foreign device. It's actually made by Astel for MegaGen. So there is no real difference between the measuring, except that the IDX unit allows you to collect the data. The Mega ISQ does not. It's like the older unit that I showed you before. So you can see that when we're dealing with the different types of bone, and you can see one of the things, and we were talking about this earlier, and that is that when you start to place the implant, if you place it with your handpiece, and I'm going to have Brian here talk about, we're very fortunate that W&H was able to bring their motors over. They have some new technology that they're unveiling at this meeting as well. So maybe because I know Brian has to leave in a little while too, to get ready for that, but you want to talk about the W&H motors and the handpiece and stuff? Just tell everybody in case they're not familiar with it.
Hi guys, I'm Brian. I'm with W&H. I'm the key account coordinator. So we're here to support Dr. Ganz, Astel, of course. So we have our current generation implant mat in front of you guys here. It's fully capable of all oral surgery and implantology needs. Not sure what you guys are using in your office. Possibly it's our unit already. We do a lot of OEMs, so we make the biocar unit. I assume all those are actually made by us. The hand pieces, we have 16 different hand pieces, 15 of which are fully dismantleable. The ones here are fully dismantleable, so you can take them apart and clean them. So in theory, if it's done correctly, that should give you a longer life of hand pieces in your office versus most most of our competitors that don't come apart. And 6 of those are with a self-generating LED. So there's a generator inside the handpiece. While the motor spins, creates electricity, powers the dials. There's no more bulbs, halogen bulbs, glass rods, that sort of thing. It's a full integrated system. And our new unit, as Dr. Ganz mentioned, is being launched tonight. And it goes on sale April 3rd. It will have an Austel system, a W&H Austel system that you can literally plug in the side of it, so everything will be on one unit as well. So there's a couple different technologies. This does the tracking, a little different than our system, where it's more of a data system. So there's a couple differences between the two. But yeah, so if you guys are looking for a system or some hand pieces for LED, the self-generating ones will work on all systems. So a couple options for you. Just wanted to say hello. Let me know if there's any questions.
So do you have any literature here, or does it be at the booth?
Actually, do not.
Okay, so it'll be at the booth. Yeah.
1322. You guys dump around. Next couple days. I'll see the beginning as well. Thank you.
Now you have that set on 800.
If that's what you guys are requiring, I think.
We'll punch it up to 1,000. So just make sure. Excuse me. Just make sure that they
Plus a couple times. If you could get the green.
they know how to do that.
And yeah, should be pretty easy from there. It's set and ready to go. So thank you. Thank you. Any questions? Let me know at the booth or now, and I'll be heading out to set up the launch event tonight. So. All right. Thanks for your time, guys.
Thank you, Brian, for supporting our program. We get to work at a lot of the meetings together, and he's a fountain of knowledge and a great guy. Besides the fact that it's a fairly good company.
That's all right.
Where's your launch event?
Down in the, actually at the Hilton, 6 o'clock if you guys want to go by. Okay.
Thank you.
Okay, so I'm going to walk you through this, and then we're going to have you guys do it. So what happens is that when you're going to place this, now are there foot pedals? Are there foot pedals?
Yes.
All right. So when we're going to go to the changing from the drilling to placing the implant, they're going to.
So either hands-free with the center orange button, or you can just literally it's basically fastest on the left.
And what is that set to? Because I didn't check it.
Right now we're doing 1,000, I think.
Yeah, and then when we place the implant, we're going to go.
Speed is set at 15 RPM, but you can adjust the torque by hitting plus or minus.
And what is the torque though?
Whatever you guys need for. We'll go from 5 to 70. So whatever you guys
35?
Yeah, let's put 35.
35 it is.
So that's when we're going to place the implants. So first we're going to drill, then we're going to place. Now we're going to place them first by the handpiece, and then you're going to probably need to ratchet. So what happens is that if you look at on here, we have 40 Newton centimeters. If you start placing your implant and it binds and does not go in, and a considerable amount of the implant is sticking up, then you probably need to change your drilling protocol, and we'll talk about that in a minute. If you're about less than a millimeter here, you can then go from where it torques out. You can then go to ratchet it in, but you still may get some binding. So what I always like to do is to flip it. In this case, I think you just have a single ratchet. We'll flip. Oh, do they give you the good ones? Oh, they gave you the good ones. Okay. So with this one, you can change the direction by changing the arrow, and we can go over that. And you can back it out and let it self-tap, and it'll even do that on these models. If it's sticking out a lot, like I said before, we're going to go in with a cortical bone drill, which is on the top. Which is on the top here of your kit. And when we do that, you can see that we'll place this in here, and it will profile the bone so that you will then be able to go back to placing the implant in, and it should go in. And we want to bury these implants about 1 millimeter below the crest. That's our goal for today. So again, if we went to the 4.5, Now, the difference between a 4.0 and a 4.5, the core body of the implant is exactly the same. It's the threads that are wider. And so the inside part of the implant is the same, it's just the threads. So you would a little bit less dense bone, and you can see that we would have a little different drilling sequence. And again, the same thing would apply, and you can see that we would then use the cortical bone drill, or I like to call it a bone profiler, because it's basically profiling the bone to get the implant below the crest. So let's just go through this real quick. So here's the drilling sequence again. Fortunately, we won't have any bleeding today. We're not going to be flapping anything. But let's just go through this real quickly. We can just go. Okay, so here's the site. Now, I like to use that lance drill. It's very, very, very sharp. And a lot of times, especially when it's flat like this, I don't go in straight like that. I'll go in at a 45-degree angle, perforate through the crest, and then straighten it out to the exact angle that I want. You may want to try that in this particular case as well. Then we're going to go in with the next one, which is the 2.0 marking drill, they call it. You can drill to depth with this drill. And you can see the pumping action. It's no different than any other drilling sequence. We're going to then go, now this one says, I think, oh, so here's our direction indicator. And this is a good thing to do, especially when we're going to place multiple implants. So we'll see if we have enough for you guys to place at least a few in this one mandible. And we're going to, this one it really is a it says 2.8 on your kit. And again, you're going to go to depth and with the pumping action. And then we're going to go to the next one, which will be a 3.3. And we may stop with that. We'll see. I want to see how these mandibles perform with the 3.3, with the motor. And then if we have to, we would go to a 3.8. So you're going to tell me how you feel that density of the bone is when you start to place it. And if we had to, we'll go to a 3.8. But that's as wide as we will go. If we need to profile the bone, we will then use the cortical bone drill or the bone profiler. Once we have this drilling sequence accomplished, we'll go to the carrier, and it's a little trick to making sure we get this off the carrier. It's mountless, so we're going to just put this in. You put it in more like a little bit of an angle, and then rotate it up. Now you see again, this is much wider thread that they put into these illustrations. I don't know why they want to continue to do that, because I think it scares some people away. But really the thread design, as you'll see, is not so wide. You'll notice that when it's buried below the tissue there, below the crest of the bone, the neck of the implant will be below, there you go, about 1 millimeter below. One millimeter below the crest. So that's really our goal. And what we're going to end up doing in each one of these, that they have their own cap, which closes the implant. And as I showed you for this particular case, we did do a delayed approach. So we're not doing any suturing today. Okay, so what we're going to do, and I'm going to walk you through this first, and then we'll go through it with everybody. You probably want to start on the patient's left side. Try to make a measurement that looks like you're far enough away based upon your experience and what you think you should be doing. And we'll start out with the spade drill. We can place one of the directional, I'm sure that we have those in the kit. If we want to go before we place the first implant, we have two ways of doing it. We can use this and then go to a second osteotomy. What I prefer you to do today is to let's get the first implant in. Just make sure that you're in the right position. Use that as a tool, as an indicator, as a trajectory indicator. Go to the next drilling sequence, making sure that, you know, as I always say, you know, if you drill into the table, you probably drill too deep, okay? And certainly if you hold your finger underneath it and you hit your finger, that's probably not a good thing. And then what we're going to do is, just like you saw in the video, we're going to take our implant and we're going to place it onto the carrier, and we're going to then position it into the mandibular bone using the handpiece first, and then we'll ratchet it below, and you see it has Megagen on it, and it will have the torque value. This is actually upside down. It should be the other way around so that you could get the torque, and it should be about 1 millimeter below the crest. So at that time, we're going to hand out the ISQ, the smart pegs, so that we can measure the ISQs. And now we'll get the IDX units up as soon as we get the implants in, and we're going to start to measure the ISQ values. So now this is an older video, but I thought it's appropriate. So basically, this is the older unit, and this might be more appropriate for the Mega ISQ unit. But you can see that when we're looking at resonance frequency analysis, it doesn't matter which unit that you're using because the technology is exactly the same. And so the question is, you know, do you ISQ? And the answer is going to be hopefully yes, because as I said, there's two things that I don't do implants without. One is cone beam, and the other is with taking a measurement of the ISQ value. Each of these has a carrier. I hope we have them here. And you're going to just finger tighten that, and you're going to make sure that it is in place securely onto the implant. Now, there are times when it can ledge against the bone or the soft tissue, and it may not actually fit properly. So you want to make sure that it is. You don't want to over tighten it. And then you can measure it, like you can see here, from the mesial, from the lingual, and you will get a series of values. On the IDX unit, you'll be able to accumulate that data. And you'll notice, like here, you have asymmetric bone. In other words, the bone is not symmetrical, so you may get one value that's higher and one value that is lower. And we can then, again, with the new unit, with the IDX, it's very easy because it charts that comparison from the day that we place the implant to each consecutive measurement that we're using. And so we can track the implants, we can tell whether or not it's stable enough, and whether or not we can, as you can see here, managing implants at risk. So this does give us a real tool to determine whether an implant is at risk or not, whether an implant should be buried for a longer time, should not be loaded, etc. This is what we are striving to achieve, is a scientific measurement that allows us to understand where we're going. And for those of you guys that are oral surgeons and you have this communication between a referral network, it's such a huge, huge tool that allows us to be able to communicate. The IDX now, being a step above the first unit, well, it's actually not the first unit, but the last unit, is just a whole nother layer of data collection that is just remarkable. And I have to hand it to Astel for coming up with this, because it really does allow us to have a collection of data that's kind of unmatched. You'll get a list of the SmartPeg reference. There's an app for that for your phone as well, and you can see that the SmartPeg is categorized not just by implant company, but also the type of implants that you have. So depending upon the implant that you're using, you will be able to look up whatever the value is the SmartPeg is that you need. So we'll be using the probe, we'll be taking the measurements with the first one. Now, the other kind of thing that you could do is that once you have this one in and you want to go place a second implant, you could leave that on there and you can use that as a parallel pin. Or within any Ridge kit, there is a paralleling pin as well. And we call that, they call it the Pathfinder. So once you place your first one, you can then put this Pathfinder, which is again is located on the top right part of your kit. And then you can go ahead and try to place a second implant. And we can see, we got 3 people here. We can see how many, what kind of ISQ values that we get. So here you see that I placed this one here, and you can see the thread. You can see the threads in this bone. We tried to mimic about the same kind of bone quality that was in this real case, because the people that made up these models were very, very good at being able to give us what we wanted. And so now we're going to place a second implant into this area, as you can see here. And we're going to go ahead and we're going to measure this one. Now, what I just did, just for the fun of it, is that I measured the implant where it's sticking up above the bone, and then we measured it once it was fully seated into the bone. And you can play around with that as well, and you can see that. Again, the ISQ is going to give us these values, and we'll show you how that works. We have a couple of people that are here. Thad is here, our Ostel crew to be able to help us with this. And that's what your goal should be. We should be able to get 4 implants, just like that. You can see here now, in the real case, I think I put this one a little bit closer to the midline, I believe. We can see that in a minute. No perforations. We don't want any perforations today. And that's the real case, just a reminder. Yeah, so I put these two a little closer together. And J.K. Kim came with his headlamps. So you'll notice that on your bench top, you have these lights if anybody wants to use those. If you haven't seen them before, this is a fantastic device. I use it every day in my practice. It's a shadowless headlamp, so if you want to use it, take my glasses off. You just put it on top of your head and screw it on. And now you got, so if anybody wants to do that, you got beautiful light, shadowless, and it works wonderfully. And we thank J.K. Kim for bringing some of those over to us to try. I'm sure he has a booth here as well.